Hello and welcome to the final session, our family history event. I'm Annwen Jones. I'm honoured to be the incoming chair of the World Ovarian Cancer Coalition, and I'm also Chief Executive of Target Ovarian Cancer in the UK. And I'm just thrilled to chair this discussion on such an important subject, and following some incredibly high quality presentations today. So for the panel discussion, we need your questions. And so please remember to post them in the Q&A section for this session or in the chat boxes. I'm delighted to be joined by my guests who will be attempting to answer two key questions. First, how can we make sure opportunities to prevent ovarian cancer because of family history are not lost? And secondly, are we doing enough globally to highlight what can be done? So these are two big questions. And I'm delighted that we have with us on the panel Dr. Adam Rosenthal, who you heard from earlier. And joining us, along with Professor Woo Ling, who works alongside Yoon Suk-hee, who we heard from earlier about that incredible MAGIC study in Malaysia and the impact that has had on scaling up genetic counselling and testing. But first of all, I would like to turn to Dr. Meghna Datta. Now, Meghna, you are in fact a gynecologist.
Yes, I am. Hi.
Working in the northwest of England, and you have family members who were diagnosed in India with bowel and ovarian cancer. So you became concerned there may be a familiar link. Can you talk to us about that?
My mother got diagnosed some 10 years ago. She's no more with us with colon cancer. And at that point, it wasn't something that we thought so much about, although I was already working in gynecology in the UK. So I was aware of HNPCC because Lynch was still not something that I had heard of. I knew about HNPCC at that time, which is now called Lynch. And on further discussions a couple of years down the line, kind of thought that my mom's sister had passed away with endometrial cancer when we were still young, and my granddad had passed away with colon cancer before I was born. So of course, they never were tested or anything. This is a while back. And then when my mother got diagnosed, thought something of it, but somehow don't know why, but never really acted upon it. And by the time we were thinking that maybe we should get genetic testing, my young sister, who was only 27, got diagnosed with ovarian cancer. She was only 27 at the time. And then where she had treatment in India under Asima, who was part of this ovarian cancer presentation with Nugena. So she operated on my sister, and we had genetic testing at the time, and she was a carrier for Lynch, so she had one of the mutations. Following on from that, I actually asked my GP to refer me. Actually, before my sister got diagnosed, I had spoken to my GP, asking them that my mother, my family members, and do you think I could be referred to the genetic services? And at that point, seemed like the general practitioner wasn't so aware of what the link could be. And they said, oh, we'll ask the question, but nothing ever came of it. And I didn't push the matter further. So after my sister got diagnosed, I again went to the GP that I think we need to be tested because it's me and one of my other sisters are around and we probably could have something here. but nothing happened for a good few months. So then I took it upon myself because working in gynecology in the NHS, I got one of my other consultant colleagues to refer me directly to the genetics team, which then took a long time before they saw me. It took more than 6 months to the initial consultation, and following on from there, having the tests took another little while. By the time the genetics test result came, I actually had ovarian cancer myself, albeit my ovarian cancer didn't turn out to be linked to Lynch. But I was a carrier of Lynch syndrome, and my other sister wasn't. So I do have the Lynch syndrome, but the cancer wasn't linked to Lynch. My mother's and my sister's was.
Thank you for talking about that. Must have been incredibly frustrating for you, that the fact the process was so long, given the family history that you had.
Yeah, I think the first time I asked my GP to refer me was in 2012, which was a year after my mom's diagnosis. And then I didn't push the matter. So by the time I asked the GP next time, this was 2015 when my sister got diagnosed, and nothing still happened. So after 2 or 3 months wait, when I got referred by my colleague, and got the results, it was 2016. And yes, so even from referral to getting a test done took about 8 months, 7 and a bit months. So it was a long process.
So that's clearly something that needs to be improved. I was just following on from what you're saying and thinking about, how do we make sure that opportunities to prevent ovarian cancer because of family history are not lost. I'm wondering, whatever mechanism is chosen to develop and deliver genetic testing, what for you are the most important factors for success?
I think education probably has a lot to do with this. Like somebody was just saying earlier on, that GPs being aware of a familial link. I think BRCA has probably become a bit better known, maybe after Angelina Jolie and getting a lot of coverage in the media. At least in the Western world, people do know BRCA, or even in the bigger cities in India, people understand a bit. But there are places in the world where people have no awareness of familial link with cancer. And Lynch probably is still lesser known. It is known among, but I probably am more privileged working in the same field as we are discussing, but most of our patients are not in that position to push the issue that I think I do need testing. So I think we need to educate our family physicians or general practitioners in whichever part of the world we are, that there are opportunities here that we could seek from. And it is best done in the general practice setting, because they probably have the biggest link with their patients. Patients come to the specialists after they have symptoms of a certain condition, but they see their GP for a lot of other reasons before they develop any signs or symptoms. So they probably can get the history side of things early before the patient develops any symptoms.
Thank you, Meghna. That's a really important point. And I just wanted to go next to Adam. Education of family doctors is really important. I mean, what other success factors would you point to?
I certainly agree.
Genetic testing.
I certainly agree with Meghna's point, and I think that these days medical schools are building genomic medicine into the curriculum. So I would hope that the next generation of doctors, at least in the UK, are beginning to be aware of this. Obviously, I can't speak for other countries, but I think I'd go further and say, actually, it's about public education as well. I mean, why shouldn't this sort of thing be taught in schools to our children? It's literally life-saving information. If you're aware as a young person that a strong family history of certain cancers might link together and might indicate that your family has a potential serious problem that is well worth consulting with physicians about. I think that would be really, really helpful, because so often the public don't find out about this until one of them gets a really nasty diagnosis.
Thank you. And can you just clarify for all of us, with the BRCA mutations, which cancers have an elevated risk? We know about ovarian and breast.
Yeah.
Are there others?
Well, there are some male cancers involved as well. There's male breast cancer, and then there's prostate and pancreatic, particularly with BRCA2 rather than with BRCA1. And the risks aren't huge. They're not as high as they are for breast and ovarian cancer in women, but they are still substantially higher than the general public's risk. And there are some ongoing studies in Europe looking at screening for, I should say surveillance rather, for pancreatic and for prostate cancer in BRCA carriers.
Thank you. And I was just thinking as you were talking there, you know, when it comes to ovarian cancer, men really do matter, because the mutations can pass through the male as well as the female line. And so when we're talking about awareness, men need to be as aware as women. Is that right?
And I have to say, I've come across a few cases in my clinical practice where patients went to their GPs with that information, that it was on their father's side of the family, and they were told not to worry about it because it didn't affect men. They didn't understand that you know, this is a germline mutation that can be passed down equally easily through the male line as it can be through the female line. So that's a really key message for healthcare professionals to understand, not just because it's primarily female cancers that these mutations cause, although of course Lynch causes a lot of colorectal cancer in men as well as in women. It's absolutely key to understand that it travels through either side of the family.
Thank you. Yin Ling, if I may come to you, is there anything that you would like to add in terms of what are the most important factors for success in developing and rolling out genetic testing?
Delighted to join this conversation. I think for the first time, many of the lower and upper middle income countries are participating in the conversations. If you look at the narrative of hereditary cancers and the counseling and genetic testing, we are all at different phases of this narrative globally. So for example, Adam, we talk about, and Meghna, you talk about GPs and education of healthcare professionals. We must remember that in many parts of the world, an individual does not have a GP. And this is where the community and the education of individuals and children as they grow up will be quite important. Then if we go a step back, the taboo about talking about cancers are a real reality in many places. Even in Malaysia, where we have an urban and rural area, it's very heterogeneous, like cancer. We have to tackle the issues quite differently. In Klang Valley, where I am and where SOE is, we have access to genetic services, social media, and perhaps more exposure to what's available. But when you move out into the rural areas, you deal with different types of communication and you don't even know what cancers their family members have. And so, you know, we go quite a few steps back talking about education. So for example, if I see a patient with ovarian cancer, extracting the family history is quite difficult, because they'll say that, oh, there's cancer in the stomach, where stomach means the abdomen. And then you say, oh, I have someone with lung cancer. And when you go deeper, it's actually a metastatic lung cancer. So family history is quite difficult to extract. in our population. But I think we're heading the right direction. The narrative is starting, but we're going the right direction.
Thank you. And yeah, as I mentioned earlier, you know, the MAGIC study, it's just so impressive what you have achieved in that study in terms of scaling up. And I sense that you are already all over the next phase and thinking about these issues, these broader issues around education and information. Thank you for that. We'll come on to the second big question in a moment, but there were some questions in the chat I'd just like to cover. So one of them was for you, Adam, and it is in relation to the ALDO study. Have you also studied ROKA in women that present with pelvic mass or symptoms? So I guess using ROKA to improve diagnosis in symptomatic women.
No, I mean, the purpose of ROKA is to track changing levels of CA125 over time. When you have a pelvic mass, you need to know with a one-off test, is that mass likely to be malignant or not? And CA125 alone does that reasonably well in conjunction with ultrasound. And so there are risk of malignancy indexes commonly used by gynecologists around the world, where you can score the mass according to its ultrasound features, whether the woman's pre or postmenopausal, and the CA125 level as a one-off. So you don't really need the ROKA test in that setting. That's a differential diagnosis setting, not a screening or surveillance setting.
Right. Okay, thank you very much for clarifying that. Okay, we'll move on. So are we doing enough globally to highlight what can be done? And I mean, how important is it to keep the focus on prevention, not just testing for access to treatments, when we're talking about genetic testing? And I guess this becomes really important when we're kind of looking at germline versus somatic testing, and just really keeping that focus on prevention. I mean, how important is that? Could I come to you, Yin Ling, on that, please?
You're talking about the carriers and the prevention, the risk reduction surgery. I think we've done a study in Malaysia. So Yi, who's on the call, we have published this. The prevention really starts from the management of the patient and their relatives in a risk management setting in a clinic, where the conversations are constant. So they need an average of 4 to 5 consults or visits before we can even address these prophylactic surgery. So there are surgical aspects, there are the financial aspects, there are the social, psychosocial aspects, which we are all tackling. That's quite different from say where you are from. And that's what we're trying to understand a bit more in terms of the prevention. If we talk about the financial aspects, currently, we'll go to insurance later. That's a bit gray on what the insurance or the financial institutions are prepared to cover.
Right. Thank you for that. Maybe we'll come on to the insurance now, because Miho mentioned in her presentation of the advocacy work that's going on in Japan, the issue of genetic discrimination, as she described it. This potentially could have quite a severe impact on the take-up of genetic testing unless it is resolved. Adam, in terms of the UK, where, you know, they have a wonderful law in the US, I think that gives protection, and we've had a moratorium for some time. I mean, what is the position currently in the UK and Europe?
So I can't speak for countries other than the UK, because I'm afraid I don't know what happens elsewhere. But in the UK, this moratorium between the government and the insurance industry has been extended again and again and again. So I'm hoping it's never going to disappear. And that is that you can't have health insurers or other forms of insurance, life insurance and so on. They can't prejudice you if you are a BRCA carrier, as long as your policy is below £500,000, which is a pretty large sum of money. And so I don't think is too bad in the UK setting. I think this raises a really important question, because it's not just about ovarian cancer or other inherited cancers. This is actually a broader question about the fact that the science of genomics has now raced ahead far faster than society has worked out how to deal with the information. And we can now predict with reasonable accuracy a whole host of quite serious conditions, not just cancers, but cardiovascular disease and dementia. I mean, there are people like those on this call working in those fields around the world in those areas, and they're all at similar levels of precision medicine. It's really getting quite impressive what you can do. And so we really risk creating swathes of society who are uninsurable if the governments of those countries don't step in and say, clearly it's for the good of humankind that you can predict disease in everyone and intervene in a way to keep people healthier and productive for their society, let alone living a long and happy life, which we all want. So I think in parallel with the science, society needs to step up to the challenge in every country and ask itself, how is it going to deal with this knowledge that enables people to predict ill health?
That's really interesting, thinking about where that takes us and the importance of international collaboration, because we kind of think of that in particular on the education front and collaborating with other disease areas, perhaps those disease areas that are impacted by BRCA. But as you say, these are broader health issues, and I think that that gives us an impetus, really, working together under the coalition to work with other coalitions to really take up this issue. There's so much we can do nationally, but actually we need to have an international response.
And when I'd like to follow up on what Adam said, because recently we've had this situation where as healthcare professionals, we were engaging with the insurers. So there's a body that looks after insurance. And what we realize is that the science have moved on so quickly for so many diseases that the policies or the guides that govern insurers are very far behind. And it's not through lack of wanting to change, but they've just not been informed. For example, in Malaysia, they weren't even aware that people living with HIV can live till a long old age now. And so I think we need to engage with them, and through the coalition with statements that will guide insurers on how they can reimburse and how their policies should be set.
That's an excellent, really excellent point. Thank you. Now, I would have liked to have covered a bit more the cost of genetic testing and the health economics, but I don't think we're going to be able to do that in this session. But I think we'll pick it up in the work of the coalition, because that's something that's come up today quite a lot: how to maintain access to genetics testing outside of the studies. So I'm going to put you all on the spot now. In order to make sure opportunities are not lost to act on family history, if you had to choose one thing, and we'll need just a few words here, that is most important to tackle, what would that be? Meghna, can I come to you?
Yeah, I think the one thing that would be most important is ensuring that people are aware that there is a genetic link basis to a lot of cancers. So probably primary education would be the one thing.
Fantastic, thank you. Adam?
Well, that's what I'd have said. So I'll say healthcare professional education. rather than public education. That'll be mine. But I think that actually public education is even more important.
Thank you. And Yin Ling.
I think it starts from personal interaction by each one of us. So if you come back to the MAGIC study, if all 83 of us gynecologists went deeper into the family history of each of our patients, I think that will have a ripple effect on how we don't miss any opportunities.
Wow, thank you, thank you. So that education and that cascading ripple effect, as you put it, really important. I feel that we could probably have several sessions on each of those points, and maybe that's something we could look at as coalition going forward, because I think this session today has raised so many important issues that we do need to continue the conversation around. But can I just thank you as the panel so much for taking part, and it's been a really fascinating discussion, albeit quite short, given all of the things that we want to talk about and say. But I think it's helped us to draw out some of the pertinent issues from the earlier presentations. So I thank you all. I think for my part, there are a couple of underlying themes that have emerged today that are worth pulling out. First of all, I think we've seen the great value that we can realize from optimizing what you have to hand by way of tools, expertise, resources, and infrastructure. So making the most of what you have to deliver the support and services that women with a family history or genetic mutation need access to, and in whatever setting. The case studies from Malaysia and India demonstrates that it is possible to provide the kind of support to women within the context of lower and middle income settings where there's unlikely to be full-scale standalone counselling and genetic testing services. And I'm just really struck by the innovation that's taking place, but also the leadership that's being shown in those countries and the personal dedication of everybody involved in those studies. I think the Australian traceback program is extraordinary. Optimizing information is being gleaned from samples from women who were diagnosed before we even understood the significance of genetic mutations or had the means to test for them. And the ALDO surveillance study is showing that in the right context, with women who are already found to have mutations, the ROKA test may have a really important role to play in avoiding delayed diagnosis. Although, of course, risk-reducing surgery, as has been highlighted, remains the most important way to prevent ovarian cancer. You know, these are all really inspiring, really novel approaches that we should applaud and we should take inspiration from. And you know, I can see several of these projects being either replicated or rolled out internationally. So lots of really practical pointers that we've had today to make progress. I think the other key takeaway is that making women aware of family history and having access to counselling and genetic testing, it's not just about accessing the latest treatments and PARP inhibitors, which, you know, they can be game changers for many women, but they're simply not accessible for the majority of women worldwide who are diagnosed with ovarian cancer. And I think what today has shown is that outside of treatment, the value of testing can be about offering women the opportunity to take preventative action. And that's hugely important when you look at the Every Woman study and the forecast of that huge increase in cases worldwide. I think 40% increase in cases. You know, we have to do everything we can to reduce the number of cases, and prevention offers a really important route. So I think, as one of the presenters put it, putting the process for counselling and testing in place now means that should treatments become available where, you know, they're just too expensive at the moment, then those countries will be ready with whatever is needed to support access. So there is a really, really strong case for creating an infrastructure for testing. And there are really, you know, these are all really important learnings for us, you know, in whatever setting we are. So I want to thank Adam and Meghna and Yin Ling for joining me and for sharing really insightful observations on these issues, and just to reiterate that the importance of education. And I'd also like to thank all of our earlier presenters, Francis, Suki, Kath and Rachel, Asima, Donna, Pooja, Mandira and Miho for sharing what really are very impressive initiatives and achievements. And thank you again to our sponsors, AstraZeneca, GSK, Clovis, Myriad and Novartis for supporting this event. We really appreciate your support. And also to our agency partner HAFT2 and Feedloop. As Elizabeth said in her opening remarks, this is our last event in our summit series. And we have learned so much from each other in each session. And in the coming year, we will continue our work on the Global Ovarian Cancer Charter and the 6 priority goals. Of course, family history is one of those. And we will be producing a series of policy updates on each of the charter goals. And we have plans for 2 roundtable events that will dig a bit deeper into the issues specifically relating to access to treatments, but also opportunities across existing women's health initiatives. And I think that Adam's point is very relevant in that context. Activity at country level on our Every Woman study in lower middle income countries will start in the new year. And we will continue to seek out and promote the work of our incredible charter champions. Please visit the website or contact the team if you have any questions about our plans, and we'd just be so delighted to hear from you, and I'm extremely grateful for everything that you do. So on that note, I thank you all for joining us today, and I hope that you found it as interesting and as inspiring and as useful as we have. Thank you all so much.